My name's Ananda Galappatti. I'm a co-director of MHPSS.net, and I will be the moderator of the session today. Welcome, everyone. Great to see you all connecting from Rome, from Trinidad and Tobago, from Liverpool, from Malaysia. Thank you, everyone who's joined us. I think it's time that we perhaps get started with the webinar. So a very warm welcome to you all to this webinar organized by the IASC MHPS reference groups, thematic working group on MHPSS, disaster risk reduction and climate change. This is what we hope will be the first in a series on MHPSS climate-related hazards and disaster risk management. And we have a really great panel today to speak with you on the topic and share with you methods, tools, and approaches to protect and promote you and your communities' mental health and well-being before, during, and after climate crises. And we're very fortunate on this panel to have with us today Katie Hayes, policy analyst from Health Canada, Davide Ziveri, MHPSS advisor from Humanitarian Inclusion, and from the World Health Organization, Ashley Nemiro, who's a consultant, and Brandon Gray, who's a technical officer in Geneva. And we will have also inputs from two colleagues on work in Indonesia and Afghanistan, Mita Chowdhury, regional advisor for mental health at CBM Global, and Mohammad Nawrooz Ibrahimi with Child Protection Country Office in Afghanistan from UNICEF. So as many of you know, over the past decade, the field of MHPSS has been becoming increasingly aware of the role that climate change plays as a key driver of disaster risk globally through precipitating emergencies and hazardous events that threaten the physical health and well-being of directly affected persons, but also by exacerbating the many social and environmental risk factors for mental health and psychosocial problems for many, many more. And we know now that the benefits of proactive disaster risk reduction can be profound, with the UN Office for Disaster Risk Reduction reporting that for every $1 invested in risk reduction and prevention, up to $15 of post-disaster recovery costs can be saved. And of course, whilst the benefits in terms of mental health and psychosocial well-being of vulnerable populations are yet to be quantified, these would also be similarly or even more profound. And I think in the recent years, we've all seen that there's been a growing recognition of the importance of integrating MHPSS within disaster risk management, especially before the onset of climate-related and other hazards, with groups like the IASC's MHPSS reference group championing the idea that integrating MHPSS within preparedness, mitigation, response, and recovery actions not only protects and supports the immediate mental health and well-being of affected individuals, but also fosters community resilience and enhances communities' abilities to recover and thrive in the aftermath of climate-related crises or in the ongoing process of change. Later in this webinar, we're going to hear from Brandon and Ashley, who will tell us about the work of the IASC MHPSS reference group. But before then, I'd like to invite Davide to share with us a short video that was produced by the reference group's thematic group to help introduce this topic to a broad range of audiences. So over to you, Davide, to just set up the video for us.
Thank you, Ananda. It's my pleasure. I'll introduce you our colleague Meera, better than me can show the video. Actually, she cannot join us in presence today, but she sent this amazing video. So with the support of Humanitarian Inclusion, MHPSS.net, and the IASC DRR MHPSS working group, she will present a 10 minutes animation video, very creative and full of insights and prompts for our discussion later, but I also hope for our field work. And she will present us an innovative device. I cannot tell you more, is an ideal innovative device, but with real strategic and practical solution, preparedness, integration of MHPSS into DRR, and community engagement. How to move forward on those points? I let the floor to Meera to show you how we can sensibilize our colleagues about the integration of MHPSS into DRR, and how also we can make the communities we serve more aware about this link. Thank you. So Valeria, please start the video. Thank you.
Meera lived on the banks of a great river. Her father built boats for the fishermen, and her mother cared for Meera, her two young brothers, and their elderly grandmother who had dementia and needed special attention. Meera was a bright and helpful girl who dreamed of growing up to be a teacher. The people who lived on the banks knew how to deal with the yearly floods that had come for as long as anyone could remember. They were also used to the storms that came up the river from the sea. But with changes in the climate, storms were becoming less predictable and much stronger than before. Meera's grandmother said that the weather patterns were now so different from what she could remember when she was younger. This year's storm was more powerful than anything they had ever seen. The weather system caused the sea level to rise and sent a powerful wave surging up the river towards Meera's home. No one was expecting this. And when the wave hit the houses, there was chaos and destruction. Some wooden houses were smashed by the wave, and others were torn from their moorings and carried by the water. Meera's home was washed up onto the higher ground and crashed onto its side. The disaster brought tragedy for many families, including Meera's. Her elderly grandmother was killed when the house toppled over, and her father's spine was seriously damaged, paralyzing him from the waist down. The family had to move to a temporary camp many miles away. Life changed for Meera after the disaster. Her mother went to work in a house in another town to earn for the family, since Meera's father could no longer work. Her father put a brave face on his disability, but Meera saw him grow more and more depressed because he could not move around. The whole family missed her grandmother. With her mother working and no one else to help the family, Meera dropped out of school to care for her father and her brothers. She lost contact with her friends who had been displaced to a different camp, and it seemed like now she would never get to become a teacher. People in the camps were often frustrated and angry because their lives were hard, and Meera didn't feel safe moving around by herself. Every day before she slept, Meera prayed that the suffering that her family and others like them faced would be relieved, and that they could have a happy life again. One night, in her dreams, she saw a strange machine. It was a disaster rewind machine that could turn back time. It had 4 settings, and Meera turned the dial to the first, preparedness. Suddenly, Meera was transported back to a time just before the storm. She could see that there were volunteers being prepared to respond to hazards and support people who were affected in their aftermath. She saw government officials and community groups discussing plans for temporary housing and assistance. A psychologist was explaining how important it was to provide social and emotional support to people who were affected by a crisis. She also explained that this would help them cope with a disaster and reduce the chances of longer-term problems. Then, Meera saw the storm surge strike again, causing terrible destruction once more. However, this time, the community volunteers were quick to come to the assistance of the affected people. They comforted Meera's family as they mourned her grandmother and provided practical support to her father, in overcoming barriers to access the services he needed. The temporary shelters were organized to keep neighbors and relatives close together. So, when Meera's mother had to work to feed the family, someone they knew helped to look after Meera's father and brothers while she went to school. At school, the teachers were especially kind to the children who had lost family and encouraged the students to help one another with practical things like homework assignments and sharing school supplies. There was one girl in Meera's class who found it hard to concentrate and frequently cried in school. So her teacher arranged for her to see a counselor who had been trained to help children who were struggling after the disaster. Meera's father also got support from a community group and received training to take up a new job at a shop. He became more confident about living with his disability. Slowly, Meera's family put their life together again. Meera looked at the disaster rewind machine and turned the dial back to mitigation and prevention. Once again, she was transported back to the period before the terrible storm. This time, she saw people, including her father, shifting all the wooden houses towards the edge of the floodplain. She saw her father explaining to the children that all the adults had discussed and agreed to do this to protect the houses from high flooding, and that the stronger, higher houses would keep them safe and reduce the risks of damage to their homes. Other people were making plans to be able to move their livestock to higher ground. The government was also announcing a new early warning system by radio and SMS message to alert people of hazards like strong storms or flooding. Meera's family also received a visit from a community health worker from her grandmother's clinic to make sure they were prepared to evacuate her if necessary. This time, when the storm surge came, Meera saw that the houses stood strong above the waves. The children and adults inside had already been warned of the danger by the government and had moved their livestock and boats to higher ground. They were all confident about the measures they had taken to protect themselves and were less afraid. When the storm cleared, there was only minor damage to the houses, and no one had been seriously injured. Even though she was dreaming, Meera cried with joy to see that her grandmother was alive and her father was walking about. Everyone in the community helped to clean up after the storm, their bonds even stronger for having worked together to prevent harm. Meera didn't want to leave this happy part of her dream, but she knew she had to turn the dial to explore the final setting: response and recovery. This brought her back to reality, where her family was suffering after the disaster. However, this time she saw people talking about how they needed to rebuild their community so that the disaster would never happen again. There were organizations helping people like her father speak about their experiences and suggest ways to rebuild the houses more safely. There was a scheme to help families like hers to start small businesses, so her mother was able to move back to work from home. The government increased the number of social workers to help children stay in school, and disaster preparedness and prevention was introduced as a topic in their curriculum, so that everyone grew up with knowledge of how to prepare for and protect themselves from hazards. This made people more confident about facing these and better able to cope with the stress of an emergency. When Meera woke up from her dream, she thought long and hard. She knew what she wanted to do. Everything the disaster rewind machine had shown her was about how people can take action to reduce or prevent the harm and pain of disasters. This was so important, but Meera wondered why people didn't do anything to stop or reduce hazards like these destructive storms in the first place. Her grandmother had said that the changes in the climate were caused by people's effects on nature, but that they didn't care enough to stop this. Meera made up her mind that she would do whatever she could to prevent more disasters like the storm that harmed her family. She now had a new goal in life. Like Meera, around the world, many people are working to address the causes and drivers of the different kinds of crises that occur where they live. Like them, we each have a role to play in preventing, preparing for, and responding to disasters to reduce the suffering of families and communities and protect their well-being. Thank you. I'd like to ask you, Davide, to tell us a little bit about why this video was needed and how it can help.
Yeah, thank you. I hope everyone enjoyed the video and is also available on YouTube. This tool seems very simple, actually, but it's very rich in content, and I think we can discuss it from MHPSS perspective for hours even. And it was really needed for two reasons, in my opinion. The first one is that it's easy to realize how much important it is to integrate MHPSS and DRR in preparedness and response to climate-related disasters. But honestly, it's not easy to do, because we are used to working by silos, by sectors, and multidisciplinary, mutual learning, and collaboration are challenging too often. So I think that Meera somehow calls us to be out of our zone of comfort, our professional habits, our expertise, and really to move away from, to not be stopped by having diverse languages, perspective, and priorities with our colleagues, and really start to work as a one team, and really looking for coordination and synergies. This is the first takeaway from the Meera video. The second one for me is that she really represents what a community is. Sometimes we have this idea of community in some project as a general concept, as something homogeneous, but actually is a place of diversity. And this diversity is, I think, well represented in the video, because if we want to ensure that DRR and MHPSS are effective together, leaving no one behind, we should understand diversity, we should recognize intersectionality, and we should promote inclusion. So it's very clear for humanity and inclusion. I'm thinking at a research we did in Nepal last year on barriers to DRR among persons with disabilities. And once again, it was confirmed how this population is most at risk, disproportionately suffer the impact of climate-related disasters, but also how many barriers they encounter, especially when we think about early warning system or evacuation mechanism, when they not follow a universal design. So for me, in the video, there is this hidden part of inclusion that is really important in terms of non-discrimination, also within this professional community, because sometimes we are not aware, simply. Accessibility, the importance of accessibility in terms of information and services, but also the importance of meaningful participation. And nothing about us without us is really crucial in policy making, but also in disaster risk reduction planning. And moreover, we know very well that community engagement and participation is crucial for building trust. And we need to invest more in trust, in empowerment in the agency, and it requires time and really proactive investment. So concluding, I think, and we know that communities are the first responders. We saw recently also in Europe, in Spain, and we see in many other places in the world, but only if their capabilities are really reinforced in advance. So we really need, I think, to reinforce those social aspects and social processes that in the videos are like the background, but actually are crucial. I'm thinking at the social determinants of health, the shelter, housing, employment, all those education systems, all those aspects that are represented in the video that are really key not only for effective programs, but also for equity. So for me, Meera and their community too are the real heroes of MHPSS in DRR. And I think that they could also become inclusion and equity champions, and we can follow their example. Thank you.
Thanks, Davide. So, this idea of the video as a sort of an opening statement to explore diverse issues and very important ones that you raise is certainly something that you've seen. I'd like to ask people on the call, some of whom might have seen the video or even used it, to maybe share your impressions and thoughts, or maybe even experiences of using the video for conversations with communities or others, and just put that in the chat. But I'd like to go to our colleague Mita now, who has had a little bit of experience of using this video with slightly different groups in different settings. So Mita, will you tell us a little bit about how you through CBM have used the Meera video, and what sorts of outcomes or reactions you've had to it?
Yes, thank you, Ananda. So from CBM Global, we have used this Meera video in 3 different places. So in Kenya, we presented this video to a group of African disaster professionals, and some of them shared that it helped them to understand MHPSS integration into the DRM cycle and to connect it with climate change. In the Philippines, the local mental health partner staff, they reflected that the video gives ideas on how to work on community-based MHPSS. While in Bangladesh, with our country team, which was a group of mixed professionals, they shared that the video is inclusive. It shows different types of MHPSS interventions mentioned in the different layers of the IASC MHPSS intervention pyramid, and how to integrate MHPSS into different sectors. And it gives an example of multi-stakeholder engagement too. This means that the video is a great tool for promoting inclusive and community-based MHPSS in the context of climate change and disaster risk management. Thank you.
Thanks very much, Mita and Davide. I wonder if any others have thoughts about how this video can be used, because it is very much a conversation opener, something that can be used at the start of larger, more substantive training programs or community discussions about issues. And I know that in the context that I work in Sri Lanka also, we've used it actually for conversations with children around the actions that they feel their communities could take in the context of hazards that they experience seasonally. I'd like to segue from the video, Meera, to the work of the thematic working group that produced this video. So I'd like to turn perhaps to Brandon and to Ashley now, and bring you in to tell us a little bit about some of the recent work of the IASC MHPSS reference group's thematic group on MHPSS, DRR, and climate change, and also about some of the interesting initiatives that are in the pipeline that I'm sure our colleagues would really like to know more about. Over to you.
Thanks a lot, Ananda, and thanks everyone for being with us. Yes, we just wanted to briefly share some other updates from what the IASC MHPSS reference group is doing in this area. Meera makes a beautiful point of how important this topic is, and it's a great example of one of the many tools that's happening in this space. And as we know, there is a lot happening, including by many of the people that I see here in the audience list today. So we won't capture it all, unfortunately, but we do want to describe some of the work that's coming from the IASC MHPSS reference group, thematic group, on this topic to support reducing risk and better preparing for the mental health and psychosocial impacts of climate-related hazards. So I just want to quickly start by saying, what is the IASC MHPSS reference group? It's a big acronym, and many of us are familiar, but some of us may not have heard. So this is a global mechanism for interagency coordination of humanitarian assistance, bringing together key UN and non-UN humanitarian partners to formulate policies, to coordinate responses, and to enhance preparedness for humanitarian emergencies. So the IASC MHPSS reference group was formed in 2007 with the main goal of disseminating the IASC guidelines on MHPSS. It now has 65 members and is co-chaired by WHO and the IFRC Psychosocial Center. Next slide. So the next question then is, what does this IASC MHPSS reference group do, and why is it important for what we're talking about today? Well, one of the key functions of the group is to support interagency coordination globally and through MHPSS technical working groups at country level, with 59 such groups existing currently today in emergency settings, including in many settings affected by climate-related hazards. Next slide. So as part of the support that the IASC MHPSS reference group provides, it conducts things like search support missions to address gaps and challenges, engages in high-level awareness raising and bridge building to mainstream mental health and psychosocial support across sectors and areas of work. And it develops key tools and guidance to support the work of MHPSS actors in the field, including in integrating MHPSS in new or emerging fields or in fields where MHPSS has often not had much of a place, such as in disaster risk management, though that has changed a lot in recent years. Next slide. So this would be where our webinar comes in today. The IASC MHPSS reference group facilitates a number of thematic working groups. And as Ananda had mentioned, there is a thematic working group within this reference group focused on integrating MHPSS in disaster risk management and climate change adaptation. So this group is currently co-chaired by WHO and TBM. And one of the main purposes is really to develop different tools like this beautiful Meera video and others to support the integration of MHPSS and DRM. So to describe a bit more about what we're doing and what we have coming, I will hand to my colleague, Ashley, to take us through a next few points. Over to you, Ashley.
Thank you so much, Brandon. And next slide, please. So Brandon mentioned through this thematic group, we're developing many exciting material that I'm really happy to tell you more about today. So we have a lot of ongoing initiatives, one of them being the development of an MHPSS preparedness and risk reduction training package called the READY package, which we're currently, after piloting, we're currently field testing, especially in areas affected by climate-related crises. And also, there's been the implementation of global capacity building workshops and simulation exercises. I think some of you on the line today have even attended those. Ongoing technical support and follow-up as it relates to disaster risk management and operationalizing MHPSS within it. And then documents of key case studies and lessons learned. And today you're going to hear some of those case studies from our dear colleagues. And then development of tools and resources, such as a risk assessment, which I'm really excited to tell you about, and high-risk topic guides. Next slide, please. So this is the READY package. And the READY package consists of 5 modules. And as I mentioned, it's really all about operationalizing MHPSS in disaster risk management work. So module 1 is really around reviewing key concepts as it relates to both disaster risk management and MHPSS. And it's really ensuring that everyone in the room is up to speed on these different concepts and terminologies. And module 2 is really around engaging communities and other key stakeholders. So as Davide so beautifully said, communities are often the first responders in any disaster. And that's why having a whole module on community engagement and really ensuring that this comes second was so important to us because it sets the stage for the rest of the package. And then module 3 is about assessing risks and resources. And this is a new tool that Brandon and I have been developing with support from subject matter experts who are part of the thematic group and beyond. And I'll share with you a bit more on that. And module 4 is really around defining MHPSS activities. And this is really pulling on so many of the incredible IASC MHPSS resources that have been developed and around operationalizing MHPSS preparedness at country level. And then lastly, it's really putting together your action plan. So what are actions that you will take within your agencies, within your organizations to ensure that MHPSS systems are being built up in the event of hazards? Next slide, please. So, development of the MHPSS Preparedness Assessment Toolkit. It's really about assessing risk and capacities for mental health and psychosocial well-being in disaster risk management. And we very much envision the MHPSS toolkit being used by government, civil society agencies, community-based organizations, and other that are aiming to develop or strengthen risk-informed MHPSS as part of disaster risk management. And really the main objective of this tool is to inform and promote well-coordinated local, national, and regional preparedness programs that are inclusive of MHPSS. So right now, as I mentioned, this tool is currently being piloted. And actually it's being piloted by Africa CDC, which is really exciting. And we will be piloting it in Bangladesh. And also just to mention that this toolkit is very much multi-sectoral, and it looks at different MHPSS activities across both health, education, social care, and also looks at high-level components such as preparedness policies and the integration of MHPSS into those policies. And it seems like the slide deck has come down. And we, of course, know that there's a number of tools that support disaster risk assessment, including in the domain of health. And these assessments rarely, if ever, consist of MHPSS needs, resources, and risks. And really no validated tool supports this. So that is why it was so important that we develop something that could be used both as part of the READY package and then, of course, on its own. And we just want to note that this tool doesn't identify hazardous events that may occur, but it does look at our agencies, our systems, our organizations ready to respond within their MHPSS system. And we also just want to mention that this toolkit is very much inspired from the MHPSS multi-sectoral assessment toolkit, which we know is used during responses. And so a lot of the language you'll see overlap between the two toolkits, and one is really meant to be used during a preparedness phase, and then as we know, the multi-sectoral assessment toolkit is used in the response phase. And I'll ask one of my colleagues to put that in the chat. And do we have the slide deck back? Okay, so I apologize that you can't see this, but I'll just tell you briefly the different components of this toolkit. So the first one is really just an overview of what the toolkit is, and then we go into a desk review. And the next part is a capacity checklist. And the capacity checklist really outlines all the different components that are essential to MHPSS preparedness. And as I mentioned, these are very much multi-sectoral. And then after that, there's a community risk and capacity perception guide. So it's an overview of questions that can be asked at community level and some exercises around community hazard mapping that can be done. And this is really to support the data that's being collected through the capacity checklist to ensure that we are understanding communities' perceptions on risk and also understanding what have communities done in the past when there's been hazards. How have they responded? What worked? What needed to change? And where do resources need to continue to be invested in preparedness? And then we go into an analysis. So you take all that data that you inputted on the capacity checklist and the community perception focus group discussion, and you really determine where are their needs. Are there significant needs, some needs, or no needs, within all those different sections of the tools. And then from there, you go to an action plan. So based on all the data you've collected, we have an action plan template that then you can determine where do we need to put priorities, knowing that there may be a vast amount of needs, but in fact, it is important to really determine what are our priorities, who needs to be involved, how do we determine success, and what is this going to look like moving forward. And we very much see this tool being used in development contexts or in protracted humanitarian crises where in fact there may be a multitude of hazards that may take place. And we also see it as something that is ongoing. So it's not done at one time point, but in fact it could be done and then you could revert back to it and really see what has changed within the action plan. So I'm excited to share with you as well that these tools will all be open source and global goods. And once we are ready to put them out in the world, we also have an email address that you can email if you have any questions. And that's mhpssready@who.int. And I'll make sure to put that in the chat. But thank you so much, everyone, and very much looking forward to the case studies that will be presented next. Over to you, Ananda.
Thanks very much, Brandon and Ashley. And I'm sure many of us will be writing to your email address to be on the list when those are released. You know, as the you know, the work of the thematic working group has progressed, you know, there's been a real sense also looking around that many of us are quite early in our efforts at integrating MHPSS and DRM in the context of climate crisis, and that we do need to do quite a bit to learn from each other. And so the thematic group has been working on trying to share case examples from different contexts to sort of guide and inform each of us in our work wherever we are in the world. And so we're really fortunate today to have two colleagues, Mita and Ibrahimi, who have consented to share with us in breakout rooms two separate case studies, one around from Afghanistan around addressing mental health and climate resilience. In that context, a case study of MHPSS and DRM integration, and from Indonesia, inclusive preparedness planning to protect and promote mental health of vulnerable populations in Indonesia, the work of CBM Global in the second case and UNICEF in the first.
Hello everyone, welcome to my presentation. I'm Mita from CBM Global. So I'll be presenting findings of two mental health projects which are linked to inclusive disaster preparedness planning in the context of mental health and vulnerable populations in Indonesia. Next. So you may know that Indonesia, it's a big country with around 273 million of population. So disability adjusted life years due to mental health conditions is 8.1%. Another issue is Indonesia linked to mental health is that many people with psychosocial disabilities, they are living in a rehabilitation center or social care institutions. So you can see that there are 49 government mental health institutions for people with psychosocial disabilities, and there are also about 150 community residential facilities. Additionally, disaster is one of the major concerns in Indonesia. So in Indonesia, earthquake, tsunami, flood, volcanic eruptions, cyclone, and drought are common disasters. Next. Now I'll be talking about Yogyakarta, which is a special province of Indonesia, where we actually implemented these two mental health projects. So like Indonesia, Yogyakarta is also a disaster-prone area. So the common disasters are also earthquakes, volcanic eruptions, and landslides. In terms of hydrometeorological hazards, cyclones, floods, drought, and heat waves. These are really common. And other secondary hazard is fire. Next. If we talk about key mental health issues in Yogyakarta, then I will share again that the institution-based mental health and social care system where human rights infringements are really a concern in this area. In addition, among provinces, this is one of the provinces with high rates of suicide in Indonesia, which are significantly underreporting, and there are stigma around it. So if we connect it with disaster and climate change, then we can say that this disaster and climate change, it has an impact on mental health recovery and institutionalization of people with psychosocial disabilities. Next. So how are these issues connected? So I think we often underexplored, but it is widely known that climate change is happening and it is negatively impacting our livelihoods and coping. So because of climate change, if people, they don't have access to livelihood, or so they will suffer from financial strains, and it will have an impact on mental health services. It means they may reduce access to mental health services due to financial strain and disasters. Institutionalization related poverty is also common in this scenario, because families, if they don't have resources to support their members with disabilities, then they are sending them to institution. Again, the deinstitutionalization, which is going out from institution and integration into family and community, it requires family and community support for livelihood, financial stress, and other barriers matter a lot. Next. Now I'm going to share how did we address this MHPSS issue. So I would like to start from the history, that why we came up with this project. Actually, the project was started during COVID-19, where we have seen that there are heightened risk for people with psychosocial disabilities detained in institutions, and we found that they are in a really difficult conditions. So it helped CBM Global to develop this deinstitutionalization project, which started in 2021 and which is going to end in 2024. The project has been implemented by IACUM, which is a disability and rehabilitation provider, and there is another local organization, which is PJS. They are mainly organization of persons with psychosocial disabilities. So as I said, there are two mental health projects. So now, as of now, I have discussed about the first project, and the second project is that building of community mental health approach developed under community mental health project, which we call in brief CEPLARI, where IACUM is also an implementation partner, and it started in 2018 and it is going to end in 2024. So to implement these MHPSS issues, we tried to implement the project through multiple approaches, like targeting legislative frameworks at all levels, like roadmap for deinstitutionalization at a national level, then supporting community support systems, including advocacy. We worked for a strong collaboration with local, provincial, and national government and other local stakeholders, including OPDs. we focused on strengthening community mental health support system to support deinstitutionalization process in line with UNCRPD or WHO quality rights and OHCHR guidelines on deinstitutionalization. So this for disaster preparedness, this COVID-19 actually broadened the scope for including MHPSS for people with psychosocial disabilities or mental health conditions and their families. But again, CBM Global decided to revise the project based on changed situation. Next. Because in that time, the COVID issue was not that much significant, but we have also explored that people with psychosocial disabilities are often excluded in disaster preparedness plans and left behind in institutions and communities in disaster events. That is why we revised the project to increase attention to disaster preparedness beyond COVID emergency. So through this project, we assisted this mental health or social care institution to develop the disaster preparedness and response guideline, including SOPs, which is standard operating procedures, which includes also how can we promote inclusion and participation of people with psychosocial disabilities, how to reduce disaster risk and human rights concerns in this institution, how to improve capacity for MHPSS preparedness and response for people with pre-existing mental health conditions. Next. So on the screen, you can see a picture of evacuation plan that was developed from this project, and it has also been included in the SOP. Next. So to develop this disaster preparedness and response plan, it took about 9 months, so which involved a committee of staff, residents who is living in the institution, and disaster preparedness representatives of the local government. They did series of meetings that aligned with country and local disaster management planning and consultations with OPDs as well. During the development of this preparedness and response guideline, they have also included simulation exercise on evacuation, and they have also practiced it. Next. So in this disaster preparedness and response plan, actually they started with orientation to relevant people who does not have much information or experience about disaster risk management. Yeah, so how do we measure the success of this guideline development? So actually, it is mainly context specific. It means that the disaster committee, they developed a disaster event history plan, which includes a brief description of impact, and it helps to understand what are the risks and hazards are there. So during this risk assessment, the Social Rehabilitation Center also recorded information about possible hazard threats and its characteristics, like likelihood, impact, possible time to recover, so that they can plan well. They have also further analyzed the risk, vulnerabilities, and capacities. In the SOP and disaster risk reduction actions based on vulnerabilities, they developed it. For example, what are the information and knowledge the people need to have? What are the infrastructures that are at risk, and how to what to do in this case? how much budget do they need, and people who has different types of mental health conditions, so how to be prepared for it, and what can be the impact of this simulation exercise, and what can be the needs to respond after the simulation exercise. Then in terms of inclusive preparedness, they also developed this disaster management team with identified role in pre, during, and post-disaster by including the persons with psychosocial disabilities or the residents. They included plan for most vulnerable, like if people having a kind of hearing issues, so they can use lights to draw attention for those people, or if there are people with bed rest, so what can be done in terms of preparedness so that they are not left behind during evacuation or disaster preparedness also. So there were active participation of residents with disabilities in evacuation management simulation too, and the attention was given to the engagement of both women and men. Next. So now I would like to share another success from the Community Mental Health Project 2, where we included people with psychosocial disabilities to prepare to be prepared for disaster in their village. So they developed their own evacuation plan. So you can see it on the screen that they have developed their own evacuation plan based on their situation in their village, and they are the members of self-help groups comprised person with psychosocial disabilities, their family members, and facilitators. Next. So what are the significance of this work? So first thing is that actually this project gave us further thoughts around climate change, disaster, and mental health. So what can be done? What is missing here? So what's the significance of these projects? Actually, these projects or this work gave us further thoughts that what can be the links between climate change, disaster, and mental health, what is missing here, and what can be done. Then the work was also life-saving, because during emergencies, if people with psychosocial disabilities, they are left behind, so they will be at life-risk situation. It also created evidence for others that how can we include people with psychosocial disabilities in disaster communication, how can we make inclusive preparedness, how can we include them during evacuation, and also in deinstitutionalization issue, how can we work on disaster also. Then modeling participation of people with psychosocial disabilities and mental health conditions. This is really good findings here, because there are negative assumptions that they cannot be included in disaster preparedness because of their conditions. So this project really helped to break these pre-assumptions. Next. So lessons learned and way forward. We found that we need to think more about climate change, disaster, and MHPSS, and we need to analyze is more, including intersectionality. Then we need to continue the participation of people with psychosocial disabilities and in DRR and emergency response process. Then we need to take measures to address situation of most marginalized and vulnerable groups, for example, who are on bed rest or who are having multiple disabilities. How can we include them in disaster preparedness, and how can we think about their mental health too? But we do need to think about different tactics for accessible disaster communication. For example, based on the condition of the person living with mental health conditions. So what are the IC materials can help them to communicate this disaster information in a better way? We also need to focus continuously on promoting right-based approaches on MS spaces in the context of climate change and disaster risk management. Next. So that's the last slide. So on the screen, you can see a plan that that was developed during the disaster preparedness and response guideline development, that how to plan for different types of people based on their conditions, and what are the preparedness steps they can take for evacuation. Thanks. Thank you.
Thank you, Mita. So maybe I will start with the first one, which says that it's great that this is being developed. And do you think that this is a model for many other institutions, including homes for the elderly, etc.?
Yes, so there is a plan that in Indonesia, the social care institution, they will advocate to implement this plan also in other institutions. But again, it was developed in social care institution, for mental health institution, or for people with psychosocial disabilities. So it can be used, but it will require contextualization where the guideline will be applied.
Okay. And then there's another one that says, I feel there is much attention to be paid to staff, self-care, mental health concerns as well. This is basically for the frontline responders. And climate change is an issue that cuts across. Would you agree?
Yes, completely agree. And I think whenever we are talking about mental health, it's mental health for all. So it includes the first responders also, because they also are the first responder and they are seeing things, and they are also affected. Or they can be also from the community who are already affected. So we must consider them too.
Okay, great. And then there's another one that says, this is truly wonderful. Was there a specific training used for us for the self-help groups?
Yes, so for self-help group, they receive training, also how they can support to each other on psychosocial issues, and they can facilitate the self-help groups. This is the training they received. Additionally, they also received a kind of vocational training so that they can have access to livelihood, and they can be integrated in the community also.
Great. And then there's a question that says, what is the impact of the case study and how did the community receive integrated services?
Okay, so during our evaluation, we found that they found the project really beneficial because it was the first time they were consulted. Mainly, I'm talking about people with psychosocial disabilities. So they were consulted, they were included in the disaster preparedness and response plan in this area. So it really helped them to build their confidence, to feel like, yes, they are valuable, they can contribute to, and also their voice has been heard.
Okay. And there's a question that says, what was the most challenging part, particularly as you were coordinating care with local institutions, which is not easy?
I think at the beginning, it took some time to bring the approach because we followed human rights-based approaches. And what I have shared also that including people of psychosocial disabilities into preparedness or other types of activities, it was not common. So it took some time to bring this awareness and this willingness. But yes, at the beginning it was complicated a bit, but later on it went really well.
Okay, great. And then there's a question about asking if there were any activities done with school-going children or with teachers or any plans related to this in this project, like child-focused PFA.
I think in this project, it was focused mainly on adults with mental health conditions. So we will see if there are scope in the next phase to work with children. But this is really important to work with children too.
Okay, and then the last question is there any advice on MHPSS implementation in armed conflict zone?
This project focused mainly on climate change and disaster context, so I cannot comment on it right now. But I mean, the learning we have from this project, we can see if we can apply it in similar contexts like climate change and disaster context or in institutionalization context.
Okay, that is the last of the questions. Thank you so much, Mita, for the presentation and for your answers.
Thank you too. My pleasure.
The catastrophic situation or scenario in our country. The first one, unfortunately, we are having more than 4 decades of conflict in our country. And the other one is the recurrent climate-related disasters that we are having. And the recent one is the takeover of the government by the opponent group by the name of Taliban in 2021, which led to a major humanitarian crisis. And in result of this humanitarian crisis, currently around 24 million population, more than half of Afghanistan population need humanitarian assistance. And also due to the many restrictions from this current regime of Taliban, they have put on women and girls. They have stopped girls to go to school above grade 6, and also they have stopped girls and women to go to universities, and they have put ban on work of females out of the education and health cluster and all other sectors. They have put ban on the women to work with the government, to work with the non-governmental organization, and also to work within the UN agencies. And then all these recurrent disasters have resulted into economic hardship and also the regime incapacity from past to the current regime to effectively respond to these different catastrophic situations, particularly the recurrent disasters we are facing. So this is the country context. I will continue with more about this. Next slide, please. So in terms of climate-related disasters, you may know that Afghanistan is very prone to several climate-related disasters. The key ones I can mention here, it is the drought. Almost more than 50% of population is affected by drought happening in recent years in north of Afghanistan and also in south of Afghanistan. We also have seasonal floods and flash floods, which is resulting into many lose of lives, beloved ones, and also disability, injuries of people, lose of assets, lose of livestock, and also it result into internal displacement of many families, and also it caused the transfer of landmines from one place to another place. You know that Afghanistan, in terms of landmine, is almost the first country, unfortunately, in the world that we have many casualties in result of landmines. And then we have extreme weather, which causes landslides, avalanches, and road closures among the districts and also among the provinces, which put the communities and families in more situation of distress, and also exacerbates the mental well-being of the communities. The other disaster-related phenomena, we can say it is earthquake. We faced two earthquakes in the recent years. One was in 2022, and the other one was recently the last one was in 22, and the recent one was in 2024 in Western Afghanistan and Herat. So these all different recurrent disasters are causing many social and damages, and also life damages, internal displacement, poverty, and these all cause and attributes to the vulnerability in terms of mental well-being of the communities, especially the women and girls. Next slide, please. So when it comes to the resultant impact of all these disaster-related hazard and disaster, climate-related disaster and hazards, so we have a few other social protection and child protection indicators we want to share with you about the child discipline. 9 and 10 children are experiencing physical or psychological aggression, and also in terms of child marriage, 3 and 10 women are past married before age of 18. And also, you know that Afghanistan is #1 country in cultivation of puppies, hashish, but recently this regime has put ban on this. But because of that high cultivation, we have 1 in 10 people estimated to be regular substance users. Also, when it comes to child labor, 1 in 5 children are engaged in child labor. Next slide, please. So here I will touch on the key MHPSS issues. We can say that the mental health status is dire in Afghanistan, exhibited by the decades of conflict and recurrent disasters such as flood, drought, earthquake, and harsh winter, and also the huge displacement inside the country, and also going to abroad countries, and the high level of poverty. So 1 in 5 children are experiencing symptoms of anxiety, and also 1 in 7 children are experiencing symptoms of depression. And this is finding of the current multi-indicator cluster survey in Afghanistan in 2023. Though we don't have enough evidence and comprehensive data and mental health in our context, but we have few. So the other one is the finding of a study from Oxford University recently in 2024 in Afghanistan. They have studied the girl population who are deprived of school education and university education. The finding is that 5 in 10 girls are experiencing suicidal thoughts, almost 50%, and then 9 and 10 girls are deprived of education, are feeling depressed. So this is the very high level of mental health issues in our context in Afghanistan. Next slide, please. So the key challenges when we are preparing for the MHPSS integration into disaster risk reduction, different phases are the mental health gap in Afghanistan is very high. It is estimated around 95%. And then less than 1% of health budget is allocated for mental health. And also the lack of MHPSS capacity within the current de facto authority, and also it is continuing from the previous government, that we have very few professional mental health workforce in our country. And the other challenge is the high level of stigma and our communities against the mental health disorders, which have caused access to care by the clients. Next slide, please. So when it comes to preparedness of the MHPSS integration into disaster risk reduction, we have started with integration of MHPSS in the multi-sectoral programs. And also we have done the response in collaboration with several partners, including UNICEF, international NGOs, and national non-governmental organizations. You know that currently we don't have formal government. It is a de facto authority, so we cannot work with the government. Instead, we are working with the civil society, with collaboration with UNICEF and directly with the communities. So we started with the capacity need assessment in terms of mental health, psychosocial support workforce, and then based on the need assessment, we developed training manuals, guidelines for different MHPSS workforce professionals, and starting with conducting TOT trainings for the master trainers coming from different international NGOs and national NGOs from all the provinces of Afghanistan. And the result of these TOTs and cascade of these trainings, we trained 14,350 social service providers on the three level of tiers of the MHPSS pyramid: family and community-based related training, non-specialized training, and specialized care on MHPSS. And also we have agreement with the partners to be standby partnership, and we had the program documents ready so that when the disaster happens, we are on time and into response to the MHPSS issues happening in the situation of disaster. Also, we have propositioned supplies related to our MHPSS program, such as tents, recreational kits for child-friendly spaces, and connexes in our different warehouses and the different zones to be easily provided when disaster happens. Next slide, please. So when it comes to the response part, we are providing both center-based response and community-based response. This connection and providing both layers of the service, MHPSS services, are proved very effective. So we provide structured MHPSS and psychosocial support, counseling, and also through the child-friendly spaces and through psychosocial counselors. Also, we provide non-structured MHPSS, including community dialogue, awareness raising, and psychoeducation and psychological first aid. We also provide for the resilience building. We provide positive parenting sessions to the families, to the parents. Also, we have established self-help groups. We are also providing life skill training and vocational training in partnership with our implementing partners, including IAM, International Assistance Mission, HealthNet TPO, IMC, and we have many other local non-governmental organizations. Through these connection and the community component, we are able to identify the cases of mental disorders and to refer to specialized care centers. As we have both rural component and urban component. So in the rural component, the social mobilizers and the social mobilizers supervisors are engaged directly with community to identify the cases and do the referrals. And next slide, please. Community engagement that we have done and the tools that we have used, it is the I Support My Friend peer-to-peer psychological first aid guideline. that we have adapted, contextualized, and we have been used. So this program is from adolescents to adolescent, which proved very effective through the field monitoring visits that and the feedback mechanism that we are using. We are also using the digital platform U-Report for messaging and feedback before the disaster and also during the response in the disasters. We also use, we have developed and printed different MHPSS educational materials, which we use for community mobilization to conduct the community dialogues. We also have created groups of local influentials like teachers, tribal leaders, grandmother groups, religious scholars, and also youth networks and the community health worker network in our country to do the social mobilization, community engagement, awareness raising, psychoeducation, and do the case identification and facilitate the referrals to the healthcare services. And also we have in the community engagement part, we have established self-help groups such as school students committees and child protection community-based structure, which we have developed more than 2,000 across Afghanistan, which we also call community shuras, which are very strong platforms where all the community influential male and female comes together and they do the prioritization and the response to the mental health issues along with other issues during the prior to the disaster and during the disaster. Next slide, please. So the lesson learned are key takeaways that we have gained through our MHPSS integration into disaster risk reduction. It is the importance of context-specific tailored programs and approaches. We need to have to look and do assessment and assess the context, and then accordingly we develop and implement tailored programs and approaches. The other one is that we cannot directly holistically implement global standards. We need to be flexible and adapt these methods and tools in the respective environment that we are having because of the Taliban or the de facto authority. Also, we need to have collaborative efforts and coordination platforms. We are having the National MHPSS Technical Working Group. Also, we have 5 zonal and the regional MHPSS technical working groups, which are very instrumental in capacity building and coordination and advocacy and collaboration. Also, we have the child protection area of responsibility national one, and also we have 5 zonal ones. So we do our collaboration with other sectors and also within the sectors through these existing platforms, and we technically support all these platforms. Also, the importance of capacity building is very critical. As in the low resource countries like Afghanistan, where we have lack of mental health professions, we have very few. So we need to provide capacity building training before the disaster happens to have ready teams, mobile MHPSS teams, and also the center where the health system infrastructure. We also did the MHGAP trainings for all the different health facility in our country and coordination with WHO and other partners. Also, the connection between urban and rural community-based MHPSS program is very instrumental and critical. Through this way, we have strengthened the referral pathway from the community village level to the health facility level and the different layers of the MHPSS pyramid. The resilience and empowerment of communities, families, and institutions are very proved very effective in our context, where we have worked with the communities prior to the disaster and also in time of response. They have been proved very effective to easily respond and effectively respond to the risk of disaster happening in our country. So now I will touch on the conclusions and key takeaways. So the integration of MHPSS in disaster preparedness is very critical in our context as we are facing different disasters time to time. Almost every year we are facing one or two of these mentioned disasters. Also the collaboration and capacity building and strengthening referral pathways within the different segments and urban and rural, and also using innovations such as digital platform, U-reports, and community and network shuras are very important to overcome the challenges. Focusing on empowering community to strengthen resilience and improvement of health outcomes is also very critical. Designing and implementation of cross-sectoral programs and partnership with CSOs, civil society organizations, in context of emergency, in context where we don't have government, is very important. And then the use of local negotiation proved to be very effective in allowing female social workers, as there is a lot of distraction from the current regime in terms of work of ladies and access to women and girls. I think this is the last slide. Thank you, and we are here to respond to any questions, queries.
Dr. Ibrahimi, thank you so much for that really important presentation and giving us a view into UNICEF's work on MHPSS preparedness in Afghanistan. We have a lot of really great questions for you that are coming in the chat, so I'll just start with the first one. And we have about 6 minutes left until we need to go back in the plenary. So the first one is, how are you able to successfully integrate women and girls in the community engagement process?
Yeah, thank you for this very good question. Sorry, I didn't mention that I have our chief, Mr. Mari, along with me, so we both will be responding to the question. In terms of involving women and girls in the MHPSS program, yeah, it is really an issue in our context due to the current regime, but we have online approaches, and also we have local online counseling. Also, we have helplines for them to reach, and then we also involve the local communities and influentials so that they do the exemption, or they allowed their ladies, women and girls to come to health facilities or the social service workforce that we are engaging. And that we are also engaging with the national authorities, de facto authority. And in some cases, we have been successful at the zonal MP level to reach and to have access to the women and girls.
Great, thank you so much for that, Dr. Ibrahimi. I'll go to the next question. You mentioned grandmothers on one slide. I believe this is when you were referring to community engagement. I'm wondering, what role do you think that women of all ages and girls play in implementation of MHPSS and DRR, considering the new laws and restrictions imposed by the Taliban? How have you met this challenge? So you spoke to this a little bit in the previous answer, but if there's anything further that you would like to say, over to you, Dr. Ibrahimi.
Yeah, thank you. In terms of this, I didn't mention in the last response that we are using the grandmother groups, which is a new innovation, we can say. And in current context, we cannot access the young ladies and girls directly. They cannot come out to the services without escort mahram. So we have established the grandmothers in our society, in our context. We have extended families, and we have an important role of the grandfather and grandmother. And the grandmother are very effective and have a strong say and voice in their families. So we do our awareness raising, our messaging, our positive parenting within the grandmother, and then they transfer these skills and awareness and behaviors to their families and teach to their daughter-in-laws and their daughters, sisters, and everyone who are at the young age and who cannot come to the gathering and decisions.
Thank you so much, Dr. Himi and Mari. That was really informative, and I'm sure that we could continue asking questions. So now we will go back into the plenary, and I will just give an overview of what we talked about here, but a big thank you to our presenters and sharing some of the complexities of the work that you're doing in Afghanistan and how you're ensuring that MHPSS is integrated into preparedness aspects. We really appreciate everything that you're doing.
Welcome back, everyone. I know that some of you were in mid-conversation at the time of the rooms closing. But I'm afraid that we just had to bring everyone back because we've got only about 15 minutes left of the whole webinar, and we wanted to give the two groups an opportunity to hear from each other about what the kinds of conversations that had been going on were. So just to say that if there are any outstanding questions, please deal with them in the chat. If we have a little time, we might also be able to take them in plenary. But for now, I'd just like to ask the two facilitators of the breakout rooms, Ashley and Brandon, to come to basically give us a little bit of an overview of the kind of conversations that were being had in the two breakout rooms. Thank you.
Yes, I can go first. So we were very lucky to have Dr. Ibrahimi present to us and his colleague Mari on the work that UNICEF is doing around MHPSS and disaster risk management, specifically looking at preparedness. So something that I was not aware of before thinking of this webinar was that, in fact, Afghanistan is extremely vulnerable to climate-related hazards. It's one of the ranked the sixth most vulnerable country in the world as it relates to climate-related hazards. And Dr. Ibrahimi spoke about the major environmental and climate-related hazards that affect Afghanistan, such as drought, which affect 50% of the population, floods, extreme winter, earthquakes, and then went in to talk about some of the major mental health and psychosocial support concerns and issues that the country is facing. For example, the mental health treatment gap is estimated to be around 95%, with less than 1% of the health budget allocated to mental health. And of course, like many places in the world, there's a high level of stigma that prevents access to care. So really importantly, Dr. Ibrahimi also spoke about community engagement tools that UNICEF is using around preparedness work. So for example, I Support My Friends, using MHPSS educational material for community mobilization, engaging local volunteers such as teachers, tribal leaders, grandmothers, which I'll talk about in a second, religious scholars, youth agents, and community health workers. And also establishing self-help groups such as school student committees and child protection community-based structures in the case of hazards. And there's been a lot of lessons learned, as we are all well aware that working in Afghanistan comes with many complexities. So for example, the importance of collaborative efforts and coordination platforms and how crucial those are to the work. Creating context-specific tailored programs and approaches, and being flexibility and adaptable to deliver services in very restricted environments. And during our conversation, it was incredibly lively, and we could have gone on for a really long time, but a few things that stuck out to me that Dr. Ibrahimi and Mari spoke about is just the need to constantly be innovative in terms of ensuring that people have access to services. So one thing that we discussed is how women and girls often cannot directly access services. So UNICEF is working with grandmothers, and these grandmothers are able to take some of the messages and important aspects of mental health and well-being and work with their daughters-in-law, and girls and women in the community. Also, because local authorities dictate what is happening in each district, Sometimes they have access and other times they don't. So they really have to think outside the box when it comes to MHPSS preparedness work. And something beautiful that they said is when we talk about disaster risk reduction and disaster risk management, that in fact is a lot more digestible and easier than talking about mental health and psychosocial support. So really using that work as a catalyst to promote mental health and well-being along the broader disaster risk management work. And this, of course, supports government approval as well. So I could go on forever, but that was just a quick synopsis, but really incredible work. And it's been quite insightful to hear from the team in Afghanistan. And we greatly appreciate them being here with us today. Over to you, Brandon.
Thank you so much, Ashley. And indeed, thank you, Dr. Ibrahimi, for joining us. Really appreciate it. And I'm sorry I missed your session, but I will watch the recording. I'm very interested to hear on this example. In the breakout room on Indonesia, we also heard of, I think, a similarly very inspiring story from CBM shared by Mita. I think really innovative also. I don't know if I'll be able to summarize it as beautifully as Ashley just summarized that example, but it was a innovative approach of focusing on supporting people living in institutions where classically we know in emergency settings they are forgotten and often left behind in many cases. And then this focus of this work was partially on deinstitutionalization and supporting people with mental health conditions who are living in institutions to be able to access community-based services. But an entry point for this larger deinstitutionalization project was to focus on disaster preparedness and actually getting institutions ready for evacuation in the case of an emergency, developing standard operating procedures for doing so, and also working with a human rights-based approach in the institution to prevent risks that would occur if there was some sort of a hazard. For example, as we all know, in many institutions, there are restrictions that people are placed in, and even including being locked in rooms, and even worse sometimes. But this project was using the idea of evacuation planning and emergency preparedness to actually focus on reducing the emphasis on those types of things and to promote human rights, and at the same time ready the institutions through simulation exercises and other really innovative approaches. So I think it was a beautiful example. It's actually made it really well done. It's maybe one of my favorite case studies I've ever heard. So thank you so much for sharing that with us all. I hope I've done it justice and stuttering through a summary. Thank you.
Thank you both for that. If anyone else would like to add to this in the chat, please do. I think we were unfortunately unable to be joined by one of our presenters who, due to, I think, the time change difference, we weren't able to have join us at the start. She's joining from Canada. It was very, very early in the morning, earlier than we had anticipated when we set this up over a month ago. But hopefully we'll have Katie with us briefly to speak. But perhaps what I could say is just invite you all. We've got about 9 minutes left before the end of the, I'd just like to invite any of the presenters, if they'd like to make a comment, a closing comment, reflecting on some of the work. Katie is here. Katie, I am looking for you, and I'm going to make you a co-host so that you can unmute yourself. Welcome, Katie. Katie Hayes from Health Canada. We introduced you, Katie, at the start of the webinar along with everyone else, but and apologies for the time difference because of the time change, but we're really glad to have you here. I'd like to invite you maybe to share with us a little bit about what you were going to open our webinar with, just and I think it really works here as a restatement of the case for this work. Perhaps. So over to you, Katie.
Thank you, and apologies for missing this very important session. And yes, I really apologize for that. But thank you so much for having me, and I'm glad I could hop on now. I'm a senior policy analyst at Health Canada's Climate Change and Health Office. where we're really fortunate to work really closely with the WHO and with the team on an international health grants program to really support this work because it is vitally important. I think increasingly, thankfully, there's an awareness of how climate change really affects the mental health and well-being of communities around the globe, and also the slow pace of action and resources that are really required to be implemented from a policy and practice perspective. So we have had the opportunity to work, as I mentioned, quite closely with the WHO on a variety of different climate and health related projects, but specifically this time around getting to do something specifically focused on mental health and really having a better understanding of what are the resources and support interventions that are going to be most supportive for communities on the ground. And the Canadian government is really proud to be a part of this. In particular, we have developed our first national adaptation strategy where we focus on a health and well-being component. So really establishing criteria to measure and monitor climate impacts to health, but also making sure that we're resonating with the mental health components. And our commitment to mental health is also evidenced by the fact that we have a mental health and addictions minister, mental health transfer to really expand access to free mental health services and a mental health strategy. And we are really aware of the increasing impacts and the risks, but also what are we doing about it? What are the actions that are being taken to ensure that there is inclusive, equity-focused support, and that we're really learning from the global community? Because I think this is the biggest piece as well, is that we know that the global community has done a lot more work in this area than we have, and also that there's such an important role to learn about the cultural competencies that need to take place, and also how the mental health impacts affect different populations differently. We know in the Canadian context that Indigenous peoples are hardest hit by the impacts of climate change on mental health, but we also know that there's a lot of strength and power and resilience in the Indigenous communities who have been adapting to and really demonstrating strong resilience to these impacts, but also what is the role to provide support. And that preparedness and response is really rooted in health equity, a focus on community resilience and evidence-based research. I think that's the other key piece that we really need to shine a spotlight on, is the role of evidence-based solutions and evidence-based research to really inform the guidance to be applied to ensure and help health professionals, allied health professionals to respond to the mental health impacts of climate change. And really delighted to have the opportunity to come today to speak with you all. Unfortunately, I missed all of the wonderful panel presentations, so I'm hoping there's a recording that I can catch up on. And I'll pass the floor back over to you and just say a wonderful thank you. And I am sure that the conversation was a true delight and very informative. So thank you very much, and I'll pass the floor back over to you.
Thank you, Katie. Actually, remarkably, even though you missed the bulk of it, your comments fit right in, and I think when you watch the recording, you'll realize why. So I think you spoke about the need for learning from a global community, and I think that's something that was certainly mentioned throughout, and this webinar was an opportunity for us to also hear from specific case contexts about the work that's being done, and certainly take away elements that we can use in our own. So I'd like to I know we have to come to a close. This, we hope, is the first in a series of similar webinars that we'll be having. I'd like to just open the floor and ask in turn. I might go alphabetically: Ashley, Brandon, and then Davide, Ibrahimi, and then Mita, to just say a last word about what your hopes perhaps for the work in this area going forward might be. Perhaps if you see any key priorities or actions that you want to highlight for us, please do share with us in bringing us to a close this evening.
Thank you so much, Ananda. And just to say really briefly that I've been very inspired by all the presenters here today, and I am just really excited about the MHPSS Preparedness Assessment Toolkit and how that can be used by different agencies and organizations to ensure that we're truly putting MHPSS first during the preparedness phase and really taking that statistic around $1 invested in preparedness, in fact, gives us $15 on return in investment. So hoping that tool can actually support different agencies and organizations to bring that to life. Over.
For me, I think the priority moving forward, there's a lot of priorities, but one of them is to actually focus on how we better integrate MHPSS, as always, right, across all types of humanitarian action. But here we're talking about within disaster risk management, right? So I think we have a lot of the tools, we have the advocacy videos, we have the messaging. We just need to keep working at governmental level with the national disaster risk management agencies in different countries to better integrate MHPSS, and we're doing that, I think, collectively, and we just need to keep doing that. Yeah, thank you, Ananda.
Davide.
Thank you, Ananda, and thank you, all speakers. For me, a priority and a dream is to set up the Meera device to our future, because MHPSS, I believe, may play really a crucial role also in building hope, and hope is a crucial hidden social dimension of DRR and climate change adaptation too. So I hope to see more of us working with MHPSS into DRR for building the future. Thank you.
Thank you for the opportunity that we were able to share our work with the global community and the webinar participants who will watch later. We are also thankful to the IASC work and the technical guidance that they are giving to us, the different guidelines. Actually, we are using the recent guideline MSP, minimum services packages, and also we have been started using the new guideline on MHPSS program for children and adolescents. Our priority will be two. One is about the integration of MHPSS in the different sectors and using the opportunities of education, health, and social protection ones in the respective environment of Afghanistan. And the other priority will be reducing the stigma around the mental health disorders. Thank you.
Yes, so what I have said that we need to work more with disaster and climate change professionals so that they integrate MHPSS into their work or their projects. Then we need to advocate for, to different stakeholders, including donor agencies. And also we need more case examples that how we are working on climate change and mental health also. Thank you.
Thank you to you all for your last words. It just remains for me to also thank every one of you who came for the webinar today. I've just set up the exit poll. Please, co-hosts, do not press end poll, because you might accidentally close the poll. This is for the participants to take the poll. Please give us some feedback on this webinar so that we can use that information to decide how we plan the next one for you. So thanks to all of you. Thank you to our excellent panel for everything that they've shared today, and have a good rest of your day and week until next time.